Shame on you, Joe, for not being a Monty Python fan.
It should be live now. I had to reboot the box, but apologies for the delay.
Thank you, Anna. So we can start.
Yes.
Okay, everybody. Well, thank you for your patience. Sorry about the delay there. And once again, apologies for my continuing IT lack of photo problems. Right, okay, good morning and welcome to the Health and Wellbeing Board. I'll just go through my script for you all. I'm Councillor Jason Fazackerley, Cabinet Member for Health, Wellbeing and Social Care and Joint Chair of the Health and Wellbeing Board, and I'm chairing the meeting today. Members of the public are invited to view this meeting and there's been the opportunity for written representation to be submitted. Board members are requested to keep their microphones on mute and only to turn these on when they're called to speak. If the chat function is to be used, please only use it to indicate your name to speak and no other comments. And you can access the chat from the horizontal menu bar, right click to bring it up and not the icon on the left hand side. Can I ask everyone taking part today to confirm they are present? What I'll do is go through, I'm not sure we're going to go through this, I can't see everybody that's on here. Can I just ask we start, hang on, let me go through the list of participants so I can see who's actually here. Where are we? Right, starting, we'll go through it alphabetically, probably the easiest way. So, Helen, if you're here, can I ask you to confirm your presence?
Yes, Councillor Fazackerley, I'm Helen Atkinson, sorry. Okay. Yes. I'm Helen Atkinson, I'm Director of Public Health at Portsmouth.
You've still got that dodgy microphone, Helen.
I've actually just got my new earplugs. I'm just about to put them in. Thanks to Andy Biddle, they've just arrived in the post this morning. I'll put them on now.
Okay, next is Sarah Beattie.
Good morning, Sarah Beattie, Head of Portsmouth and the Isle of Wight for the Probation Service.
Thank you. Seema Begum. Seema, are you there?
Yes, I'm Begum. I'm the Domestic Abuse Analyst for Portsmouth City Council.
Thank you. Sarah Daly.
Hi, yes, Sarah Daly, Director for Children, Families and Education.
Next, I've got Democratic Services 4, which I assume is you, Anna.
That's Anna Martin, Democratic Services, and the shared laptop is D4.
Okay. Diane Sherlock.
Good morning, Councillor. Yes, Diane Sherlock here, CEO of Age UK Portsmouth and representing the voluntary sector. Thank you.
Okay, next is Penny. Is it Emirates Penny?
Good morning. Yes, Penny Emmerich, Chief Executive at Portsmouth Hospitals.
Thank you. Frances Mullen.
Good morning, Frances Mullen, Vice Principal, City of Portsmouth College.
Thank you. Lewis Gosling.
Morning, Councillor Gosling, Conservative representative on this committee.
Thanks, Lewis. Matt the Stat Gummerson.
Good morning, Matt Gummerson, Strategic Lead for Intelligence, Public Health Portsmouth, here to support the items on health and wellbeing strategy and pharmaceutical needs assessment. I've got some stats if you want them though.
You surprised me, Matt, thank you. Councillor Susie Horton.
Morning, everyone. Susie Horton, Cabinet Member for Children, Families and Education.
Thanks, Susie. Claire Jenkins.
Morning, everybody. Claire Jenkins, District Commander for Portsmouth Police.
Thank you. Dominique Latouze. I hope I said that correctly.
You did. Thank you. Dominique Latouze, Consultant in Public Health at Portsmouth City Council, here to deliver the update on the physical activity strategy.
Thank you, Dominique. Anna, we've already mentioned you. Councillor Kirsty Miller.
Good morning, everybody. Kirsty Miller, Councillor for Charles Dickens Ward and Labour Opposition Spokesperson for Health, Wellbeing and Community Safety. And as always, Elle has made an appearance in the meetings. So sorry about the cat.
Nothing wrong with the cat. David Moorman.
Good morning, David Moorman here from Portsmouth City Council Sports and Leisure Service.
Thank you. Kelly Nash.
Hello, Kelly Nash from City Council, providing general support to the board and also presenting the item on the local outbreak engagement board.
Thank you, Kelly. Co-chair Linda Coley.
Hi, I'm Dr. Linda Coley, clinical leader for Health and Care Portsmouth, and as you say, joint chair of this board. Thank you.
Yeah, thanks, Linda. Jacqueline Powell.
Morning, I'm Jackie Powell, one of the lay members for Portsmouth CCG. Thank you.
Thank you. Roger Batterby.
Hello, I'm Roger Batterbury. I'm the chair at Healthwatch Portsmouth.
Thanks, Roger. Councillor Jeanette Smith.
Morning, Councillor Jeanette Smith. I'm sort of present. I'm opposition spokesperson for PPP.
Thank you. Leader of the council, Gerald Vernon-Jackson. Gerald.
Sorry, I was on mute. Hi, I'm Gerald, leader of the City Council.
Thank you. Chief Exec, David Williams.
Morning, everybody. David Williams, Chief Executive, Portsmouth City Council and the board member of the CCG.
Thank you. And last but by no means least, Lisa Wills.
I'm always last. Hi, I'm Lisa Wills, and I'm presenting with Bruce Marr the domestic abuse strategy. And don't forget, we've got the domestic homicide review meeting afterwards for those community safety representatives that are required to attend. Thanks.
Thank you. Right. Unless I've missed anybody, holler out if I've missed any of you. I think that's everybody. Ah, Joe's arrived. Yes, Joe York.
You missed me. Joe York, Managing Director, Health and Care Portsmouth, representing the CCG and the council.
Okay. For some reason you don't appear on the list of participants, Joe, but obviously I can see you're here. So it's worth missing you out. Right. Okay. That's everyone then. If we move on to apologies for absence. So far, I've had 5 apologies for absence and 1 for lateness. Just to confirm, Andy Biddle, Adult Social Care, Professor Anita Franklin from the University of Portsmouth, and she has replaced Professor Gordon Blunn, Gordon Mavuti of Solent NHS, Rachel Roberts, Adult Social Care, and Susanna Rosenberg of Solent NHS. As I think Anna touched on earlier, Lucy Rylett from Children's Safeguarding can't be here till 11 AM, so if we do reach our agenda item prior to that, we'll have to put it back. Item 2, sorry, no other apologies, I take it, Anna?
No, none aware of.
Thank you. Declaration of interest. Does anybody have a declaration of interest to declare? If so, I can see no indications. So, nope, that was short and sweet. Moving on to item 3, which is minutes of the previous meeting. We need to ensure this is a correct record of the meeting held on the 24th of November. Are there any comments or amendments anyone wishes to make? Yes, Jacqueline.
Hello, thank you. It was a query really on the minutes, and one, it stated on page 2 that capacity has increased in the urgent treatment centre at St Mary's, which is amazing and to be congratulated, but I thought they were really struggling actually to with high vacancy rates. So just wanted clarification.
Okay, is anybody more technical than me able to assist on that one?
Yeah, I can help with that, Jason. I don't know if you can see my hand. Yeah, Jackie, I think from the previous position, their staffing had definitely improved. We've been monitoring that, and we have triggers and thresholds for their staffing, so they've definitely increased their staffing capacity at St Mary's. A lot of that has up until now been through agency staff, but it was it definitely is in a better position than it was at the previous meeting, so that was accurate. I think we also need to reflect that it still hasn't returned to its previous opening hours, which is 8 till 10 PM, so it's still operating at 8 AM to 8 PM, and we're working with the service to get back to 10 PM opening as quickly as we can.
That's brilliant. Thank you, Jeff.
Yeah, thanks for the clarity. I see no one else indicating, so can I ask for a proposer for approval of the minutes?
Proposed.
Thank you. And a seconder?
I'll second.
Thank you very much. Okay, so the recommendation proposed and seconded. We apparently now need to take a vote, but there is no dissent, so that's fine. We move on to matters arising from those, and I don't think there's any either. Any questions or any matters on those? Any comments? Nope. Thank you. Okay, moving on to item 4, the first substantive item, Local Outbreak Engagement Board update. Kelly Nash, that's for you to go to. Thank you, Kelly.
Thank you, Councillor Fasakli. So this is just the regular report that comes at the beginning of each of the meetings, updating on what the activity of the board has been since the last time you met. There have been 3 meetings since the last meeting. The group continued to receive updates on data intelligence, or as I believe we're now calling them, MAT stats. We're doing the test, trace and isolate updates on a regular basis, and also considering the vaccination programme rollout in the city, and also receiving regular updates on policy and legislative changes from the Director of Public Health and the Head of Regulatory Services. The group also consider on a regular basis the key risks to the city, and just identified and report the ones that have been noted at the most recent meeting, which generally include the business continuity impact of the continuing infection rates, and also the expectation they'll start to see further illnesses start to increase coming through the system. The dates in the diary for the meeting run until April, at which point we'll consider what the future meeting pattern needs to be and make a recommendation to bring back to this board at the next session. As I always say, there are other members of the board present at the meeting who will be happy to comment if there are other things that I've missed or wish to bring to your attention. But otherwise, as I say, just a summary information report and happy to take questions.
Thank you, Kelly. Do we have any questions from anybody? I cannot see any. Nope. Okay, well, thank you very much, Kelly. That was
Thank you.
Short and sweet. Okay, moving on. Item 5, health and wellbeing strategy. And Kelly, I hope you haven't gone away because it's you again.
Oh, I think Helen might be introducing this one.
Oh, sorry.
No, that's right. And can I just check that you can hear me now, Councillor Fasakli? I've got my headphones on. Thank you. Brilliant. So I would just like to start by saying a huge thank you to particularly can I thank Matt and Kelly, who have done quite a lot of the hard graft behind this, but I also want to thank everybody that has obviously been part of the process for getting us to today, which is this report, which is in presenting the final health and wellbeing strategy for 2022-2030. And we're asking today for the board to adopt it. So as you'll all be aware, because the draft came to the last board, that people have been working very hard together, and that includes the board members on this over a number of meetings over the past year nearly now. So just to say, to go through, I won't go through all the background, but you'll be aware section 3, for those of you who have had a chance to read it, section 3 really talks about all of the background and who's contributed. And so again, I'd like to thank everybody, both at the contributions, both at the board meetings, the many workshops that Matt and Kelly facilitated over the last few months, the consultation, which we had a good response, and also obviously for the work going into the final version. So since we last met in November, when you saw the draft strategy, which went out to consultation, we've received nearly 500 responses to that consultation, which I think we were very pleased and to get. It's quite a good return in terms of a consultation and a report like this. All of the responses are detailed in both section 4 and in appendix A. And overwhelmingly there was clear support for the priorities that we have all worked on over the last year and identified. So respondents put forward lots of additional ideas that will obviously inform the plans that we are now at the next stage going to be developing for each of those priorities, and where issues were raised as part of the consultation in other areas that are not covered by the strategy. We share those with the appropriate organisations, whether that is other parts of the council or Health and Care Portsmouth. So all of those, all the consultation responses will be followed up. So section 5 explains in more detail how the strategy will be delivered, monitored and evaluated. And we've now identified board level sponsors for each of the priorities. So I'd like to thank everybody that volunteered or accepted the ask. So again, thanks to Penny Emmerich from Portsmouth Hospital, who's going to take the lead for air quality and active travel. Thanks to Claire Jenkins from the police for taking the lead in positive relationships, and also for stepping up and joining Sarah to Daly, who is also taking the lead for education. So thanks to Sarah. David, thank you for agreeing to take on housing, and I'll be working as lead on poverty. But each of those areas, as well as the board champion and lead, has a member of staff leading and doing all of the work with them. So we're not asking people to take that responsibility on their own. So but saying that, those people, thank you for agreeing to take the lead. But what we are also expecting and asking is sort of all partners and organisations and members of the board to play their part. For this to be a successful strategy, it has to have everybody both owning it and obviously contributing, because it's the might of all of our organisations taking the strategy on board and delivering it that will make a huge and an important difference to residents of Portsmouth. So Matt and Kelly, who have led all of this process over the last year, and each of the priority leads and officers will work to take forward the priorities and new ways of working that the strategy sets out. So in section 6.2 proposes a work programme for the short to medium term, which we're hoping to bring back to the next meeting of this board for approval, and that will just describe how we intend to work and what we're intending to do in more detail. So finally, section 6 also recommends that the Health and Wellbeing Board approve obviously the strategy, and that's why we're here today, but also requests that each of the organisations in the partners organisations of the board consider the strategy at their own boards where appropriate, and this will include recommending the strategy to the City Council and obviously the CCG governing body. So that's all I have to say. Luckily I've got Matt and Kelly here with me if there's any questions, but otherwise we're asking you to approve the current final publication.
Thank you, Helen. Do we have any questions or comments from anybody? David.
Yes, thank you, Chair. Yeah, I'd certainly endorse the recommendation. I think it's a really strong piece of work. I don't want to sound sloopy-shouldered in this, and I'm delighted to accept the challenge and the mantle of the lead for housing. But it does just bring back to the forefront of my mind something I've been thinking about for a while, and that is that housing is fundamental to health and well-being. It's one of the absolute core building blocks, and I would quite like at some point to bring a paper back to you for you to consider whether the Director of Housing, not just on behalf of the City Council but on behalf of the housing sector, might be considered a full member of this board. I'm sure were the Director of Housing on the board, they would have led that piece of work. But it's not that I don't want to do the work, I promise you, but I do think it's really important. The Director of Housing plays an important role on Health and Care Portsmouth. And I think it's also really important, particularly whilst the changes in terms of the structure around health and social care are going through, that we really give emphasis to the wider determinants of health. So really that's just a marker, I guess, for the future. Thank you.
Thanks, David. I think that's a perfectly sensible suggestion. I'm not sure the legalities of how we do that, but I'm assuming we can accommodate bringing the director on if everyone's in agreement with that. But before we make a decision, can I go? I've seen another hand up from Kelly.
Thank you, Councillor Zachary. I was just going to follow on from David's point that we do need to bring a paper tidying up a few items of membership to the board at the next meeting anyway. So really happy just to incorporate that as part of that wider paper. And yeah, we'll issue the invitation in the meantime to observe, and then we can always co-opt at the meeting if the paper's agreed, which we've done in the past with attendees. So happy to take that forward.
Splendid, thank you, Kelly. Anybody else? I can see no more hands. So, nope, that's it. Oh, sorry, I do. Jacqueline.
Sorry, it was a bit last minute. I fully support this report and the contents and the large amount of work that's gone into it. It looks great to me and it feels right. The the question I had was around the respondents in terms of creating positive relationships, where the largest majority sort of answers were didn't agree or disagree with that. Do we think that's because people were unable to really understand or unpick what was being asked? Because I think it's fundamental. I was curious.
Thank you, Matt. I see you stuck your hand up. Are you going to reply to that?
Yeah, happy to. As you say, it wasn't that people disagreed with it being a priority, it's that people didn't know. And I think exactly as you identify, I think it's probably the priority that on its own, if you just glance at the wording, is kind of least intuitive as to what it's suggesting. And I think, you know, you as a board did a lot of work over quite a long period to understand what we were meaning by that as a cause of the cause and how that underpins things. So I think looking through the comments that were associated with it, I'm comfortable that it was I think not that people weren't clear exactly what it was that we were looking to do, and I think that's something that we need to think about as we take forward that piece of work. And I think there's some learning for us as well in terms of how we consult on documents, that in terms of providing that kind of background information to people about how we got to them as well, maybe in a bit more depth.
I entirely agree. That sounds, yeah. Thank you, Matt.
Thank you, Deputy Leader Horton.
Thank you. I just want to make a comment really about partnership and strategy. Maybe it's slightly towards Kelly as well. I think I want to make a meta strategy comment in the sense of I think it's a brilliant strategy, and I thank all the board sponsors, as we're calling them, for doing their work. But I want us to constantly be aware of how this strategy fits in with other strategies, because we talk about partnership all the time, and actually it's a good thing to talk about partnership, but there's a strategic level to that. And just refreshing the content of this, it just reinforces to me how important it is strategically. We need to have those conversations with those other partners as well.
Okay, thank you very much, Susie. Councillor Smith.
Just to follow up on what Councillor Horton has just said, it's also the sort of the baseline of it. It should be restorative practice as well. So it's making sure that runs through all strategies, including all the work and operational work that we do in any of our various organisations, to make sure that because restorative practice gives you the platform to sort of move these strategies forward, and I think that's going to be a great asset if we can all do that.
Thank you, Jack. Good point. Kelly.
Thank you. Yeah, we're just going to absolutely support what has been said, and I think the really important thing about what we've tried to do with this refresh, and I think absolutely taking the steer from the board all the way through, has been it's not just about setting out actions we can take, but the way we're going to do those as well, and defining a different way of working together and actually tracking what we're doing as we're working. So I think, as you said, actually thinking about how the strategy, both the actions set out in here, but also the ways of working we're trying to promote through it, are threaded through everything, is absolutely paramount and will be paramount to success. So yeah, really support the comments, and we're very, very mindful of that in the work that we're doing.
Thank you, Kelly. I can see no other hands. So, okay, that's agreed. Thank you very much, everybody. We can move on to items. Oh, no, we can't because Lucy's not here yet. So we'll have to skip item 6 and do that when Lucy arrives. So if we move on to item 7, which is the domestic abuse strategic refresh, and that's Lisa.
Hello. Right, this is Lisa and Bruce, and I'm just going to give a brief introduction. Bruce is going to pick up a couple of the recommendations, and then we'll hand it over to you for discussion. So what you've got in front of you is the refreshed domestic abuse strategy. So the original strategy was written in 2020 and approved by the board in January 2020, and in April 21, I think, we had a new Domestic Abuse Act came into force, and that Act brought in a raft of new requirements, statutory duties, etc. One of which was to have a domestic abuse strategy group, which we already had, which was great. But one of the things that we hadn't done was to have focused in on the needs of survivors and their children in safe accommodation. And CIMA was employed with some funding from the Department of Levelling Up and stuff to undertake a needs assessment of the needs of women and children in refuge accommodation, safe accommodation, not just refuges, actually lots of different types of safe accommodation. So rather than produce a separate strategy for that, which was what the requirement was, we thought we would refresh our existing one and include it in there. So it all becomes part of the same document. So you'll see the document's very similar. It's the same structure as last time. Part 1 sets out the vision and ambition and what the data's telling us, and that's updated with our more recent analysis from our strategic assessment of crime and community safety that was approved in November last year. And also a summary of where we've got to in terms of delivering the 2020 document from our new domestic abuse monitoring framework, which was developed as one of the actions in that original strategy. The priorities remain the same, but with the addition of one priority around safe accommodation, around making sure that we're doing the work that we need to do around safe accommodation. Interesting, David mentioned housing there, because we're working much more closely with the housing service now, and I think we're going to do some good work in the future, and we've got a good action plan there that we can build on. The key findings from the safe accommodation assessment are on page 9, if you're specifically interested in that. We've also added a section to accommodate the learning from, sadly, our 2 domestic homicides, which happened over the last few years. The first of which will be discussed after this meeting by the community safety partners. And part 2 is then the delivery plan. So we've rated the delivery plan and taken that to the domestic abuse strategy group, and that was approved, I think, in January, where we've assessed where we're at with all those actions. So the focus then for this next year or next 2 years will be on around safe accommodation and around perpetrators, holding perpetrators of domestic abuse to account. There's a second. The first recommendation there is to approve the plan, which I hope you've been able to read, and that I'm happy to answer questions on. Both Bruce and I will be. The second recommendation there is around data provision, and one of the Sam Graves, who is our community safety analyst working alongside CIMA, now has had gathered lots and lots of data over the last 18 months, and the monitoring framework is really good. We're lacking in some data from health, and GP data is one of the big gaps. So I spoke with Joe York couple of last week, I think, and we've agreed that we'll how to plug that gap. So, but what that recommendation does is just really ask you leaders of your individual organisations to make sure that data that we need to monitor our progress and to understand whether we're making a difference in people's lives is available to us, so that we can do that. So Bruce is going to talk about the other 2 recommendations now in terms of the allocation of funding. Over to Bruce.
So 2 proposals in relation to our new statutory duty to provide support around safe for victims of domestic abuse who need safe accommodation. They are paragraphs 2.3 and 2.4. Just a brief summary. As of last year, the Domestic Abuse Act received royal assent and became law. Part 4 places a statutory duty on Tier 1 authorities to provide safe accommodation and to have a statutory partnership board, which includes police and health representatives to oversee delivery of those functions. There's a requirement that we do an annual needs assessment and a 3-year strategy. The strategy has to be published which we will do. That's not a problem. We've always published our strategy, and there is funding associated. So the table on page 2 or page 102 is the summary of the funding received for 21-22. We have yet to receive confirmation of funding for 22-23. We didn't receive this year's funding until March or April last year, so we're not worried. But obviously, if funding isn't confirmed, the proposed funding allocation wouldn't be committed. So the request is to approve the funding proposals pending confirmation for the Department for Levelling Up Housing Communities, and if there's any funding changes or changing allocation or changing needs, for decisions to be made by the Domestic Abuse Strategic Group. That's it, Lisa.
Lisa, you're on mute.
Sorry. Okay. So that's it, really. Has anybody got any questions or anything that needs explaining a bit more?
Yeah, we have one question already. Councillor Smith.
Yeah.
Morning, both. How are we integrating the sort of the voluntary sector? Because obviously there's quite a few organisations that are in domestic violence.
Mm-hmm.
So do they play a part in this strategy? And if so, how do we integrate them?
They absolutely do, Jeanette. One of the things that we agreed to do in the first strategy was to set up a practitioners group, practitioners forum, which we've done. We've had only one meeting so far because of all the difficulties with actually getting it up and running in the over the last year or so. But we took the revised strategy to the practitioners group in October last year, and we had a big discussion about it, and they were happy with what we've produced. We are looking to them so that group includes the voluntary sector. It includes lots of different practitioners, frontline practitioners, and we're going to be using that group to review progress and to test things like the flow chart that the referral processes, and making sure that we're keeping those up to date, and that we understand when internal processes change, that everybody's on the same page. So that's how we're incorporating them at the moment. Sadly, we lost our chair. We had an excellent chair from the probation service, but and despite pleading with Sarah, we're not able to. She's moved, so we are looking for another chair. I think Bruce and I have got that as a job to do.
And Jeanette, the partnership board has to have voluntary sector involved in it. So our commission providers, Stop Domestic Abuse and Victim Support, are part of the board as well that oversees delivery.
Brilliant. Thanks very much.
Thank you. Kirsty.
Thank you, Lisa and Bruce. I came across quite a shocking situation a couple of weeks ago, which I have been working with Lisa and Bruce about. And to cut a long story short, 2 women who lived in private sector housing had been harassed by workmen employed by landlords, employed by private sectors, to go in and take out some works, and basically it came down to them sending explicit pictures to these women. So it's quite a dreadful situation. But what came out of the situation also was that there appears to be a bit of a gap within private sector housing. So you say that you're working with housing. Does that include private sector housing? And if so, what work will you be doing with landlords and estate agents to ensure that they're working alongside this strategy, please?
I think, well, Bruce and I will both have something to say, and that my view is that this is a new piece of work that we're starting as a result of the safe accommodation requirement. Teresa O'Toole and James and Mark are all involved in the discussions. We're just at the beginning of that process at the moment, and obviously we're aware of the issue that you raised. It's perfectly feasible for the private sector housing lead, Claire, to be part of a small working group, I think, that we're going to just kickstart it with, and look at all the things that we need to do around housing, local authority housing, private sector housing, private landlords, etc. So that's it's a work in progress, Kirsty, and we'll keep you informed. Bruce.
And one of the recommendations from the needs assessment was about housing associations become accredited in what's called DAHA, Domestic Abuse Housing Association. So they have specific policies around supporting victims of domestic abuse and them as employers. So we're working with housing associations in relation to that.
It's the Domestic Abuse Housing Alliance. It's a group, right. Yeah. And what we would be looking for is accreditation to that group.
Okay, Lewis.
Thank you. Just a quick one from me to say thank you for bringing this to us, and it looks really positive that it looks like almost a gap that we've had previously that we're now able to really look at and providing all those safe options. So it's a really positive report.
Thank you, Lewis.
Thank you.
I can't see any further hands raised. Nope. Okay, so we can go back to the recommendations as mentioned by Lisa and Bruce. There are 4 recommendations for us. Rather than go through and ask anyone individually, can I just see it? Has anybody actually got any problems with any of the recommendations? Nope. So we can take that as agreed. Okay, thank you very much, Lisa and Bruce. That's fine. Those are agreed. If we move on to item 8, which is refreshing the blueprint for health and care in Portsmouth, and that's Jo.
Hi, thank you, Councillor Fazackley. Yeah, so the blueprint will be probably familiar to all of you on this board because it's been since 2015. The Portsmouth blueprint has been the underpinning philosophy really for how we've developed Health and Care Portsmouth and the delivery and transformation of our health and care services in the city. It was a 5-year strategy that came to an end in 2020, and I think had some real commitments for how we would work together as, particularly in that time, health and care statutory partners in the city, and the focusing on the integration between the local authority and the NHS, but also between the different bits of the NHS, and particularly how we developed new services in the community for people in their communities through closer working with primary and community services. So Portsmouth GPs coming together through the Portsmouth Primary Care Alliance, their GP Federation, and working closely with Solent NHS Trust to look at how we could deliver more join up of services and some real successes in that, both in that health and care services. So the local GP enhanced service office, the integrated primary care service, is a real success story that came from the blueprint and providing far better quality out of hours services to people of Portsmouth than we had previously, and also the work between the local authorities and adult social care in particular, and Solent NHS Trust around supporting discharge and preventing admissions to hospital, and the development of the PCAT service, the Portsmouth Clinical Assessment Team based down in St Mary's, which has been a fantastic service development through the pandemic. So as well as that, we've also seen a greater join up of our integrated working and feeling very much a single team, particularly across the CCG and the local authority, which we've talked about before. So we've probably come, things have moved on since we did the blueprint in 2015, and obviously since the pandemic. So we've been doing quite a lot of work together over the last 12 to 18 months. It's taken longer than we would have liked because of the pandemic to really refresh those blueprint commitments and priorities, and to think about what does that integration, what does that health and care model need to look like in the future. And you will have been involved in that because we had some development sessions back together in July, and over the summer people were asked to comment on those. So we've collected all of that in to really review the commitments in the blueprint, and also to look at that in light of the development of the ICS, what that health and care integration journey will mean, post July 2022, when the CCG ceased to exist and when our staff will become part of the Hampshire and Isle of Wight ICS. But again, I think what we've focused on and the commitments and what's come through really strongly from everyone we've talked about is the need to design services with people in their communities, so that people can access as seamless a service as possible and that is joined up across authorities. So whilst the boundaries of health particularly may change, what we're aiming through the blueprint and these commitments is that those boundary changes don't affect the way people deliver services, that we continue to operate without boundaries and to work across organisations, and that our staff and our teams are empowered to work across those organisations as well to improve outcomes and experiences. So they're the commitments. We've still got quite a lot of work to do on this, to be honest, but hopefully you'll see that this reflects the diversity of our population and how we continue to engage with local people and deliver services locally for people where that makes sense to do so, but also to make sure that where we can benefit from joining up and providing things at scale, we do that as well, and we work with our other partners across Hampshire and Isle of Wight to do that as well. The next steps are continuing to work through the development of the ICS and to understand what that means for place-based services and what that means for how Health and Care Portsmouth fits within that. And we're influencing those discussions and what a place-based delegation offer might look like. Alongside this work, we're also working really closely with the council to look at how we can bring more of our money together in an aligned way to have that greater transparency across the Portsmouth pound. So if the board is happy with these commitments and that they feel they reflect the philosophy of the blueprint moving forward, then our next steps are to bring all of that work together, to go back out to the children's teams and the adults and public health teams, and to work really closely with P3, the Portsmouth provider partnership in the city, to develop the priorities and plans that will sit underneath the blueprint for so our next 5 years delivery plan, if you like, and to pull that together into an updated Health and Care Portsmouth prospectus, which we will bring back to the board later this year, probably about April, May time, I would suspect. So yeah, if you're happy with and you're happy to approve these commitments, then that's the next stage of the work, and we'll be back in April or May to with an update.
Thank you, Jo. Jacqueline.
Hello, I know how much work has gone into this, and I'm very happy to approve the commitment. There's a but, the one that I feel is important, that I feel is important, that's come from an old version, is improving outcomes for Portsmouth people will be at the heart of place-based working. That feels like a good overarching that introduces the rest of our commitments. It doesn't seem to be that bold statement about improving outcomes. That's at the heart of what we do. So that's one I'd like to retain and perhaps put it at the top.
To put it back. Okay, so thank you, Jackie. I think that's helpful. That the intention was definitely not to lose that. And in fact, actually, what the work Kelly and I have been doing is to work this through aligned with the health and wellbeing strategy, so that we can see those outcomes and actually start to look and to work how we demonstrate that we are having an impact on those outcomes. So we absolutely don't want to lose that, but we'll make sure that is much more visible in the final iteration if it's not already. Thank you, Jack.
Thank you.
Thank you, Jeanette.
Yeah, it's a query really. Does this blueprint look at the gaps in provision? And I'm thinking of like dental care. Does it look into that and how that can be approved across the board?
Certainly in its first iteration, Councillor Smith, it didn't, because NHS dental provision has been provided or commissioned up until now by NHS England. So in the first iteration, it wasn't a responsibility of the CCG and so would not have been reflected in there. so we were focusing much more on primary medical care and community services at that point. I think obviously and as we said, the world has changed quite dramatically since 2015. When the ICSs come into place, the integrated care systems, from July 2022, they will take responsibility for dental care, optometry and pharmacy as well, for the commissioning responsibilities of those. So yes, I think it's absolutely right that in our blueprint we would be mindful and want to look at where we have those gaps, particularly in dental, because it's such a big issue for the city. It hasn't flown through from the previous work, but yeah, it's absolutely should be, and we'll make sure that we have those plans to cover that. We're doing some work within the ICS and with NHS England and with the university and public health colleagues to look at what we can do to improve provision around dentistry. It's a complex picture, and there are some real workforce shortages and issues around the contract, but we're trying to look at what we can do locally to improve and can reflect that in the blueprint.
Thanks, Jay.
Okay, Roger.
Thank you, Chair, and thanks, Joe. Really good piece of work, and I'd like to commend Jeanette for raising dentistry before I did, because it's Healthwatch Portsmouth's biggest post-bag issue, and yeah, it'd be great if it comes under the ICS to look at. The Department of Health and Social Care published the integration white paper today, and just thinking of all the work that we've done in Portsmouth, Portsmouth is mentioned. And it says, in Portsmouth, local authorities, health trusts and voluntary organisations combine their knowledge and expertise to improve support for vulnerable people in the community across a range of different services, including health visiting, school nursing and learning disability support. So mentioned in the report today, but yeah, just thought I'd flag that one up. So thanks, Joe.
Thank you, Roger. It's good that we've mentioned. I have to admit I haven't read it yet, so that's my task after this meeting.
Okay, thank you both. Gerald.
I thought it might be helpful just to report back that David Williams and I met with people from the ICS a few days ago. I was concerned by what might be happening before the meeting, and I was more concerned by the end of the meeting. My fear is that the feedback I get from paramedics and people in the service is that people who are Portsmouth residents get a better service getting out of hospital and getting home and being supported at home than Hampshire residents. Because the way in which the council, the CCG and the hospital work so closely together, and that's not so true for residents who live in Havant, Fareham or Gosport or other places. And my fear is that the close working, because we are an outlier and do it better than Hampshire, that the creation of the ICS will make things go backwards in terms of integration, because we're actually an exemplar in this. And I asked, in terms of people who are going to be on the board, how would we make sure that there's a Portsmouth voice? There was no answer to that. I asked how Portsmouth could be involved in looking through the short list of people who are applying to be on the board, to make sure that Portsmouth had an ability to have some influence, and there was no answer to that. And I asked how people involved in the City Council, what place there was for us as decision makers within the different tiers that they were creating, to make sure that the Portsmouth voice is heard, and there was no answer to that. My worry of things that are cross Hampshire is that Portsmouth voice is often lost, and yet our needs are very different to other bits of Hampshire. It may be said unkindly, that with previous police commissioners, their highest priority appeared to be sheep rustling in Alresford, when we actually knew that there were significant issues that are different in the urban areas of Southampton and Portsmouth and Basingstoke that weren't being addressed. So I think I came out of that meeting with higher levels of concern that the outcomes for residents of Portsmouth will be worse going through the ICS than the current system, and that we will move backwards in terms of integration between the health service and the city council. I hope I am proved wrong, and David may be more optimistic than me, but I think it is right to flag up that I think the likelihood is that the health service will try to do everything itself at a distance significantly away from us, and we will be done unto, not worked with.
Leader, thank you for that. And you preempted me because I had a discussion with Andy and David, and I think it was last week, where David raised the very issues that you just touched on. So I know David's got his hand up to speak, but if I can let Joe reply to that, then we have about 4 speakers to follow. So, Joe.
And it's not Joe's fault.
Never said it was.
Okay. I didn't know if you wanted me to come in towards the end of that. I think the design and development work of the ICS has been challenged by the pandemic. So as we've come into major incident level for over the Christmas period, the work the ICS team were planning to do with local places, local authorities, has been delayed. And that hasn't been helpful. I think it was a conscious decision at the time to make that delay, but I think it has caused concern, and that the ICS has had to then try and unpick some of that. So those development and design task groups are restarting, are being relaunched. We should be represented on those. I know David and Andy have been having conversations with other local authorities, and I would agree we do need to be very clear what the operating model is for the ICS, and how do we work with our 4 places based on those upper tier local authorities: Southampton, Hampshire, the Isle of Wight and Portsmouth. How do we reflect? So I agree, Gerald, we need to reflect the needs and be very clear what the needs are of the populations in the 2 cities, because there are differences, and there are differences between us, but there are also similarities. And Southampton also has also got a good level of integration with its local authority as well, and they are very keen to protect that. So, you know, we really want to flag that, and are definitely promoting those messages throughout the ICS conversations. The key is to get that operating model right and to understand what the delegation into place looks like, and then how do we work and support our local delivery systems within that 4-place based footprint. Because for QA, and I'm sure Penny may well want to come in, it's very important that we don't have those differences around the sort of the QA boundary, because it's not helpful for anyone, least of all the population. So how do we use the ICS as an opportunity to get a greater integration across the whole Hampshire footprint? Has to be where we focus our energies, and we've certainly been having those conversations. And then how do we continue to play locally in Portsmouth and South East Hampshire? I think, just to assure you from my perspective, Gerald, that we're working really hard to try and make sure that what you're worried about doesn't become a reality, and the integration work and pushing the boundaries with the Section 75 and the prospectus is absolutely to to continue to say that we can't go backwards in the city, the needs of the population are too great, it won't be helpful. So we are really doing that work, and I think now, as we come out of that major incident, the ICS is in a place to listen and to restart that development and design work, and it's probably beholden on all of us to influence that in the best way we can, I think.
Thank you, Joe. David next.
Yeah, thank you, Chair. Yeah, I mean, it's certainly not all Joe's fault. I think what I would say, I'm trying to give it a more positive spin than Gerald did. I think what I'd say is there's a lot to play for. Yeah, it's been a long struggle, and the NHS definitely, it's not just a tin ear, it's a turned ear to local democratic accountability as part of its structures. And I think we're going to struggle to really address that, because I think that's quite deeply ingrained. And I'm not convinced that the bedpan falling in Tredegar or wherever it was is necessarily heard in the corridors of Westminster, which I think was the original intention. And it was one of the planks of the original NHS that was never actually planed and fitted. But I think what I would say today, and we will continue to keep battling with this, and we need to do so on a number of different levels. It's important in terms of democratic accountability and democratic engagement, and yes, we do need to keep pushing on that, but that is a very local government centric viewpoint. I think for this board, the more we can be clear, sure-footed, have really thought through, as we are doing, not just our priorities, but also our values and our principles and our ways of working, the better equipped we will be as a place within the system to engage both with our colleagues on the provider side, who are represented at this forum, Portsmouth South East Hants, and also across Hampshire and the Isle of Wight. And I think it's interesting, Roger, referencing the mention in dispatches in the white paper. I think the more we can keep our agenda progressive, the more we are delivering on outcomes for our residents, whether they are social care clients, whether they're patients, whether they're just residents of the city, the stronger the position we're going to be in to clearly engage at all those other tiers that we will need to do. So, I think there are a few things on the agenda today which will really help us in that quest. And, we won't give up. We'll continue. We might be a little bit like the White Knight in the Monty Python film, but we will keep battling on. But we need to take our colleagues with us, and I'm thinking particularly of Penny, who has a very different footprint to deal with than we do on Portsmouth. But that relationship between what we do around the city boundary and how we shape and drive our energies, and how we can assist on the Portsmouth South East Hants agenda, and then more widely, I think is really important. Thank you.
Thank you, David. It was a black night, by the way. Diane.
Thank you, Councillor. And hopefully David and Gerald are going to like what I'm about to contribute. I have been pursuing this very case since 2019 with fellow voluntary sector colleagues, because it has been a concern of ours, and where in particular my organisation is called Age UK Portsmouth, we don't want to be left out of the runnings and the people of Portsmouth go into a hospital in Hampshire. It's really important that we're understood to have voice, and in fact I can thank a meeting with ICS commissioners in early 2020 for my bout of early COVID, and I haven't stopped shouting about our existence since. So I do believe we're all on the same page. We do have to continue to be noisy because it would be so easy to be left out. And I'm delighted to report that the voluntary sector input to contributions via Action Hampshire begins next week. And there are many voices like my own who are attending every meeting. I mean, there is no doubt I won't be at every single meeting, and I'm sure many colleagues feel exactly the same way. Portsmouth voice, Portsmouth population, Portsmouth well-being as a whole is paramount to this whole process, and I really want to reassure everybody and Gerald that we're fighting the good fight, is how I'll word it, and we certainly won't give up. So colleagues, really appreciate all your work, and we're there in the background and helping, and hopefully we'll get noisy if we have to. So thank you all very much.
Thank you, Diane. Final hand I've got is Penny's.
Thank you, Councillor. I thought I should come in response to David and Joe's invitations, and thank you, David, for describing some of the complexity around this, because of course our trust covers a greater population than just Portsmouth City, but that doesn't mean that the outcomes for Portsmouth residents are not equally important. So in my mind, we've got to make sure that we don't make this an either or. So from my perspective, the Portsmouth South East Hampshire footprint is our catchment population for the acute trust, and therefore from a delivery perspective, Portsmouth South East Hampshire is the lens through which I consider how do we make sure that we're offering equal services for any patient who visits our services. What I think we have to do through the ICS, though, from a planning perspective, is in the same way that we have for the health and wellbeing strategy here, describe the difference in outcomes that we want for the whole population. And I see it as a bit of a translation. So at a Hampshire and Isle of Wight level, what are the outcomes that we are seeking to improve? And then be able to say, and specifically for Portsmouth, Southampton, Isle of Wight, Hampshire, that means we're going to focus in these areas. And then I would expect, as a provider who is responding to that, to have to look at that and say, so for Portsmouth City, these are the outcomes that we're looking to deliver. I have to pay as much attention to the outcomes for South East Hampshire residents. So it's how do we have that coexistence of delivery on a slightly bigger footprint, but planning for the specific needs of our particular population, so that you don't just get a generalisation of things, but you do make progress on the specifics that are most important for particular populations.
Thank you, Penny. Joe, do you make any comment on that?
Yeah, I would agree, Penny, and I completely agree that it shouldn't be either or. We have to do both and all of that. And I think the design and development conversations within the ICS need to enable that in the best way possible. And how do we get that delegation model that will enable us to deliver that and to build on the strength of integration that we've already got in the city, not just with the local authority, but with voluntary sector partners, and how do we support our GP colleagues as well, and dentistry to manage some of those issues that won't go near the acute footprint, if we get it right and we're providing them with the right healthcare. We also need to look across the boundaries, as you say. So that's the task, I think, ahead of us within the ICS, and to influence that and to work together to try and get the right outcome, and to trying to shape that complexity in as simple as way as possible, so that it is clear and we understand who's doing what and who's accountable to what. And that's what that design piece is there to do. So hopefully that will really start to ramp up in the next few weeks, and it won't all be right from the 1st of July, and we've got that opportunity to keep going and to keep reiterating it and developing it and getting it right. And I think we are ahead of some of those integrations. The work we're doing to look at bringing more of our money together in a joined up way that's aligned and transparent will help, and we should be proud, I think, that we're pushing boundaries not just locally but nationally with that work.
and be able to then demonstrate what outcomes how it improves outcomes as well, because there's no point doing it if we don't make a difference from doing it.
Thank you, Joe. Jacqueline.
Sorry, that's just to completely echo what everybody has said. I think if we've got a strong place, excuse me, we're in a position to do even stronger work at the Hampshire and Isle of Wight level and at the intermediate level across the hospital footprint. And I'd like to think that if you've got strong tiered working, then the planning is up and down and left and right, so that what is needed at Portsmouth might be shared across the wider footprint, but the voice of Portsmouth also gets that opportunity to influence at Hampshire and Isle of Wight level and at the hospital acute footprint level as well. So the stronger we are at place, I think the easier it makes the system to operate. That's my personal view, and I think it's important, like you were saying, that the voices and the planning is up and down and not just necessarily from the top downwards. Does that make sense? Thank you.
Thank you, Jacqueline. Right, I have no more hands raised from anybody. So can I thank everyone for their contributions? There's good points made, and I hope the concerns that have been raised are resolved. There is simply the one recommendation for this, which is that we approve the refreshed priorities. Again, unless I have anybody that's got any dissent with that, I can't see anybody, so that is approved. There's still no sign of Lucy, as far as I'm aware, so we'll need to move on to item 9, which is... Oh, sorry, Lucy, are you there? My fault.
I am. If you're waiting for the PSCP annual report, I am here.
Oh, yeah, sorry, my fault, I didn't see you there. Well, we go back to your item then, Lucy, item 6. The floor is yours.
Thank you. You had the annual report sent to you with the papers, so I won't talk you through it. So just to give you some highlights, this is the second report that's been published by the partnership since the legislation changed and we moved from being a safeguarding board to a safeguarding partnership. So the purpose of the annual report is that it pulls from the 3 statutory safeguarding partners, the CCG, the police force and the local authority, and reports on the activity undertaken by the partnership during the period. And this was from April 2020 till March 21, and should look at not only what we did, but the evidence of the impact, an analysis of any areas where there's been little or no evidence of progress, and report on recommendations from what were serious case reviews and now are called local safeguarding children practice reviews have been implemented. So during 2020-21, the partners were also responding to the learning and recommendations that came out of the joint targeted area inspection that we had towards the end of 2019 that looked at the quality of the safeguarding response to children with mental health concerns. So the highlights, obviously, COVID and the resulting lockdown obviously had a massive impact on families and how the workforce could respond to safeguarding concerns in Portsmouth. And the partnership were very impressed with how quickly everyone pulled together, found new ways of working. In particular, the link coordinator process was very quickly stood up to ensure there was sufficient oversight of the most vulnerable children in Portsmouth. And to support new ways of working, as a partnership, we developed guidance for the workforce on having safe and curious conversations when having to work with families remotely via telephone calls, over video calls like we're doing now, rather than face to face. We also kept that sharp focus on the work within the MASH, that being our front door into safeguarding, and that was routinely reviewed throughout the year via a multi-agency quality assurance audit. And these demonstrated that we have a good and effective multi-agency safeguarding hub that's routinely ensuring that families are getting the right support based on their level of need. And the quality of contacts from schools in particular appears to be improving. The partnership and our training team have done a lot of work with schools, helping them understand thresholds, the support they can offer, and then identifying when families do need to be escalated. And that really seems to be improving, and their understanding of the thresholds appears sound. As a partnership, we responded to new ways of working. We moved all our meetings online, but more importantly, we were able to quickly pivot and put our multi-agency training online and redesign that so that even during this period, we were still able to make sure the workforce development retained a sharp focus. During the year, we published 2 case reviews. Child H died as a result of respiratory illness alongside complex disabilities, including epilepsy. The reason that this was a serious incident was that at the time of their death, they were on a child protection plan for neglect. And then we had Child I, which involved the tragic death of a 9-week-old baby who at the time of their death was found in an unsafe sleeping position, co-sleeping with their mum on the sofa who had been drinking. So following the learning from the case reviews, what we've done is we've launched a rethink process to strengthen the escalation process and support practitioners in working with stuck cases, and or to provide a mechanism for them to resolve professional disagreements relating to safeguarding work with the family in a more timely manner. We've also developed a more robust course that looks at relational practice with families when we're trying to deliver key messages around the safeguarding of babies. So we know that mums know to put baby in the cot, feet to foot, safe sleeping. However, we know that's not happening. So we're looking at the relational based practice to help work with families, to help them really embed those messages rather than just keep retelling them over and over again. We also, during the year, we launched or relaunched the Lurking Trolls campaign, which is aimed at building digital resilience in children. We know that children are spending more time online and facing more harms. So we've really launched this whole new campaign that wraps around our junior school aged children to help build their digital resilience, as well as giving resources to families so that they can do some of that preventative protective work themselves. And we've worked with our partners across Hampshire, Isle of Wight, Portsmouth and Southampton, known as HIPS, to launch a new child exploitation risk assessment framework. So the tool now considers criminal exploitation, county lines, trafficking, modern day slavery, as well as sexual exploitation. But more importantly, it's the same tool being used across all 4 areas. We've got a lot of health colleagues on the call, and our police force, obviously many partners work across the whole of the wider geographical area, so we now have the same risk assessment tool. So those are the highlights from our annual report. As you can see, we're mainly through this year. Our priorities for this year are really to support the work of the safeguarding strategy for Portsmouth. That goes beyond the work of just the partnership, but has 10 priorities, objectives set out in there. We're also working on the Safeguarding Improvement Hub. What we know from our safeguarding reviews is that we do a lot of work. We launch a lot of new strategies, protocols, models, ways of working. However, seeing that reflected on the ground within the workforce is sometimes quite frustrating. We see the same messages being repeated. So this is using an action learning set model with our senior strategic leads within organisations to look at what are the cultural, organisational barriers in actually implementing and changing the way that the workforce works with families in reaction to the learning. So that's it from me, unless anyone's got any questions.
Thank you, Lucy. I can't see any hands up at present. There is no recommendation attached to the report, so it's a report for noting as far as I can see. We do have a hand. Jacqueline.
I really wanted to say just thank you for a really excellent and it's a comprehensive report which highlights some really great practice, So as for me, I just wanted a couple of updates because I reckon, you know, like you say, this is a year that's almost passed. So do we know if the new service of transitioning of young people to adult services, has that work been completed?
So we've got 2 pieces of work that are ongoing. So we had the Mr. D Safeguarding Adult Review and the Child G Learning Review that were published 2 years ago now, that looked at the transition of young people with complex health needs, medical needs and disabilities into adult services. What we know is that all of the agencies have completed their recommendations from that piece of work, and there are transition protocols for both children to adult services within the local authority, but all of our partner agencies have also reviewed their transition protocols. And adult services have recruited a transition manager who's going to be working across services to help improve the experience of those young people. Because we want to understand the impact of this work, not just to know it's happened, this last 2 weeks ago, the Adults Board and the Children's Partnership jointly launched a deep dive into the new transition arrangements, and that will be reporting to both Adults Board and Children's Partnership in April, May time, to look at the impact, whether what we've done has gone far enough and effectively enough.
That's brilliant. Thank you. And the only other quick one, and I don't know how appropriate this sounds, but there was Operation Keepsake, which was a focused piece of work looking at the relationship between children and older males. And I wondered why it was specifically older males. I guess it's a numbers thing, but we also have to have in our awareness, it could be older females, it could be older non-binary. It just has to be an appropriate relationship.
They were just a few of the operations that we highlight in there, the ones that we support as a partnership. There are many other pieces of work that happen beyond that. We just have a very strong directive from the DFE and the national panel that they want us to keep our annual reports as short and succinct as possible. So I only drop in a few bits. I can assure you there's other work that happens that looks at those concerns.
Thank you, that's superb. Thank you.
Thank you. Jeanette.
Yeah, just to say to thank Lucy and her team for all the hard work, and I recognise that it was a sort of a skeleton report, because there's a lot more that goes on behind the scenes, and I think you need to be commended for an excellent service. So thank you.
Thank you.
Thank you, Jeanette. I see no more hands. So, as I say, this is a report for noting. So, duly noted.
Many thanks.
Thank you very much. Thank you, Lucy.
Bye.
Thank you.
Okay. We move back onto the agenda, and we are now at item 9, which is the draft pharmaceutical needs assessment update. And it's Matt.
Thank you, Chair. Yeah, so the report sets out the background to this, but essentially pharmaceutical needs assessments are a statutory requirement on health wellbeing boards to oversee their production, and our updated P&A has to be published by 1st of October 2022. Working backwards from there, as detailed in section 3.3, there's a timeline for developing it that includes the statutory 60 days of consultation, which we intend to begin on 1st of April. So with that in mind, and given the timings of the health wellbeing boards, what we're seeking from you today is approval for that process around the consultation and drafting, agreement that the draft P&A can be signed off by the joint chairs of the health wellbeing board ahead of its publication on 1st of March. And also there's a statutory requirement for the health wellbeing board to respond to consultations from neighbouring health wellbeing boards on their pharmaceutical needs assessments. And again, seeking permission for the Director of Public Health to respond to those on behalf of the board, and for the health wellbeing board to note those responses at its next meeting. The rest of the report sets out the background around pharmaceutical needs assessments and the requirements and what roughly will be in the draft P&A. And I will leave it there. Happy to take questions on that.
You indeed have a question, Matt. Gerald.
Matt, when we normally get papers here about pharmaceutical stuff, it's almost always pharmacies trying to close and stop any of their opposition being able to take over because they want to rig the market. Is this what's happening here?
So the P&A is our opportunity to set out any need for pharmacy that we think there is in the area, any gaps that we want to identify, and then that then forms the basis when new pharmacies wish to open as to whether they're meeting an identified need. It doesn't allow us to prevent closure of pharmacies, but it does form the basis against which we respond to those.
Matt, I don't mind pharmacies closing. What I really object to is pharmacies closing and saying no other pharmacy can take over that premises, because that removes choice. And the bit I think I find most worrying is that people always talk, oh, it's only a 20-minute walk to the next pharmacy, but that's for somebody who's healthy. They don't do it on the basis, how long is it a walk for somebody who's 80 who's got a dodgy hip? So I would want us to look very closely at this to make sure that we're actually serving the needs of the vulnerable populations of the city, not just be about increasing profit margins for pharmacy chains by withdrawing services from people in the city.
Yeah, and unfortunately, it just doesn't give us a mechanism for preventing them from closing pharmacies, but we can include within that. It's up to us to identify how we choose to identify where there may be need in the city. The challenge would be that if you limit it to what's within comfortable walking distance for an 80-year-old with disabilities, then effectively that's the entire country, and it would be difficult to identify a specific need on that basis. So, but we can certainly look at the walk times within that.
So, Matt, what I want to do is try to find ways of stopping people shutting pharmacies and removing services from local people.
Yeah, and I'm not sure that's
rely on
something
your creativity to be able to find a way of doing it that is at least marginally legal.
I can certainly look at how we can reflect that in the P&A. I'm not sure it's going to be a vehicle that will entirely enable us to do that, unfortunately.
Okay, but we should be trying to stop. We keep getting pharmacies shutting in the city, and that removes services.
Point taken, Joe. I'm not sure that's within our control, but I'm sure Matt can apply himself.
We get asked to sign these off, Jason, all the time. Pharmacies are coming to us and saying, is it okay to close and make sure it's more difficult for local residents to be able to get to a pharmacy?
Okay, well, you've made your point, and I'm sure Matt will do what he can. Joe.
Yeah, I suppose on that, Gerald, I think we have lots of opportunities now for electronic prescriptions for people as well. So it's making sure that we're able to support people to access things in different ways. And I guess my question, Matt, was some of that information about the role of pharmacy and how it might develop might sit either in the CCG or within the ICS, and is there anything our teams can do to support you through this process, and is there any risk to support you may otherwise have got as the NHS goes through the ICS change? Just to flag so that we can support as required, really, and happy to continue to do so.
Joe, I have to say, as a resident, and as also carer of somebody who is older than me, the idea of electronic prescriptions is laughable, completely ludicrous, and has no place. It's difficult enough getting surgeries and pharmacies to cope with low technology, but all the feedback I have about people trying to cope with electronic ones is that it's a complete non-starter and best avoided.
Okay, sorry, Gerald. Maybe I didn't mean electronic. I meant that a lot of the pharmacies do deliver, so they can arrange those delivery of the prescriptions to the person rather than somebody having to walk if that's a struggle for them. That's what I was referring to. Apologies if I used the incorrect terminology.
I'm sorry, and Joe, I'm coming back because all the stuff is saying in the advice we're giving to people: don't go to the doctor, go and talk to your pharmacist. Take the pressure off primary health, and yet we're shutting pharmacies, so you can't go and talk to your pharmacist. So we do need to take a stand on this.
No, I appreciate that, Gerald. I was just trying to flag that we can support people to access things in different ways, but you're right, a pharmacy is a really first
port of call for many people in their help. My point was really just to make sure that Matt had the support from the NHS team in this process as he needed, and happy to work with him if that's not there. Sorry.
Well, there's one thing, Joe, the supermarkets don't seem to be closing their pharmacies, so they seem to be fairly stable, but point taken. Linda.
Yes, thank you. I just wanted to make sure that hours of opening are going to be considered amongst this, not just locations, because certainly in daytime, as doctors, we've got quite good choice of how to get prescriptions to patients with deliveries and things, but come out of hours and weekends, we have no delivery is just not offered. Patients have to pay for taxis if they want their meds delivered, or district nurses have to go and get them. And at some points in the day, that means all the way up to Drayton, when obviously for South Sea residents, that's just not a doer. So if we could look at hours of opening, particularly in the out of hours period, that would be really helpful.
Thank you, Linda. Helen.
I would just like to, not that Matt needs any protecting from me, but just please don't shoot the messenger. It is a statutory responsibility for health and wellbeing boards to produce pharmacy needs assessments, and the obvious choice is for public health to do that work. The commissioners who make those decisions that Gerald is unhappy with are actually NHS England. I do recognise Joe's already explained today that obviously that role will be moving into the ICS, which I think will be a good thing for us, because we will be able, much like dental commissioning also, will have much more say and be able to support. But what comes with that statutory responsibility is rules for how we do it. I would like to thank Matt's team, because I think this isn't particularly our favourite piece of work, and to be perfectly honest, I don't think it's the most important piece of work that we have to deliver. I think there are more important. John might not be happy I say that, but it's a role we have to deliver, and if we're unhappy, I think we should be feeding back to NHS England rather than Matt, because Matt doesn't actually have the ability to change how pharmacy work within Portsmouth, or whether, how they're commissioned. But he's perfectly able to protect himself, and I'm sure he's going to come back and say something similar.
Thanks, Helen. Matt, you're next. You want to come back fighting?
No, I was just going to thank Joe for the offer of help and assure that we are engaged with colleagues from the CCG already who are providing information that we need, and also with NHS England in terms of the information we need for the pharmaceutical needs assessment itself. We work jointly across Hampshire and the Isle of Wight with our neighbouring health and wellbeing boards, so we have a joint steering group, so we can just engage with them and the local pharmaceutical committee once, but they will provide all of that information. And Dr. Colley, yeah, absolutely, we will include the opening hours within that. It's always a challenge with these things, in that we have to take a kind of snapshot in time with the best available data we can get. So we've done that work for this draft. So that'll be based on the opening hours as at the end of January this year. They'll probably have changed again by the time we publish the draft, and they'll change again before we publish the final version in the summer. But we will include that as best we can, including in the mapping work around access.
Thank you, Matt. I've one hand left. Is that an historical hand, Gerald? Or are you wishing to hog more?
I am wishing to hog more. It's very helpful, Helen, to think that if we're moving from NHS England, because they're the people who've refused to come and talk to the Health and Wellbeing Board about their removal of dentistry from Portsea and Paulsgrove. So with a bit of luck, a greater Portsmouth ICS might do better than NHS England.
And on that point, there are no further speakers. So there are 3 recommendations, colleagues, that were asked to approved as per normal. Any dissent to any of those? I can see none, so we are happy to approve those. Moving on, item 10, physical activity, and that is Dominique.
Thank you. Thanks everybody. This is the paper, the last paper in the agenda, just for noting, and there's an update for the board on system-wide work to increase physical activity. So the paper is in the notes, and I'll just give a brief overview of that, and happy to take any questions at the end. So it really emphasises the way that we are facilitating, we as a system and as a board are facilitating opportunities for incidental physical activity, so not just organised exercise and organised sport, but also the activity that you take while you're walking for the bus or playing with your child in the park, all of those incidental physical activity opportunities. So taking that really broader view. So if we think about physical activity in Portsmouth, as you know, physical activity and being active is a fantastic preventative measure, and can prevent around 20 chronic diseases. It can improve your mental health and manage long-term conditions. The former Chief Medical Officer, Liam Donaldson, referred to it as a wonder drug. It would be if it could be in pill form. So it's a great way to emphasise that preventative medicine approach. There are also huge indirect benefits in terms of reducing air pollution through active travel, and also through social cohesion, through more social mixing if more people are travelling around through walking and cycling. So a really great opportunity for the city. However, in Portsmouth, we know that around 20% of adults are taking less than 30 minutes of physical activity every week. And those living in the most deprived areas are more likely to be sedentary. So there's a real health inequalities angle to this as well. Also, we know that most recent data from the National Childhood Measurement Programme nationally and regionally showed that significant increases in year 6 overweight and obesity. So clearly a concern for the city. So in terms of strategic priorities, there's 2 main strategic priorities. There's the physical activity strategy that we brought here to a previous meeting. That's a Hampshire and Isle of Wight regional physical activity strategy that we produced in conjunction with the organisation Energise Me, and it was launched at the end of July last year in 2021. And the focus is really there on reducing health inequalities and focusing on those who are least active, and so the potential gains are the highest with that group. And then the second priority is really obviously around the health and wellbeing strategy that we talked about this morning, and the aim within that to lead active and healthy lives in a city with excellent air quality and sustainable transport. So that active travel and air quality strand of the health and wellbeing strategy obviously has great relevance for physical activity. And then underneath those strategies, there's a number of multi-agency programmes to increase physical activity across the spectrum of individuals and groups, which are all outlined in the paper, and include things like the Let's Bounce Back weight management programme, funded by what was formerly Public Health England. There's the physical activity sequin for social prescribing and GP practices. There's the Superzone pilot, to increase activity and improve weight in children around Charles Dickens, and the School Streets trial, all of which I know multiple partners around the table are already involved in. Also outlines sports and physical and facilities strategy, and the PCC, Portsmouth City Council sports and leisure provision in the city, including plans for Eastney Swimming Pool, the Wimbledon Park Sports Centre Pyramids Leisure Pool, and Bransbury Park, looking to refresh those facilities there. As I said, the paper really tries to take that broader view of physical activity. Really looking at those direct and indirect influences that can have that impact on physical activity. So looking at specific multi-partner delivery programs, but also the broader co-benefits and the synergies, particularly with topics on climate change and sustainability. And I mentioned air pollution there. So it also outlines work on active travel, on the built environment policy through the health impact assessments, through the greening work within Portsmouth City Council and with partners, and also sustainability and partnership working through the Greener NHS programme through the Portsmouth Climate Change Action Board and the Portsmouth Air Quality Board, all of which are driving, no pun intended, efforts to improve active travel and physical activity. So this is really just, like I say, an outline so that to highlight the ways that the strategy, the Health and Wellbeing Board strategy can really facilitate all those plethora of ways that we can look at physical activity in the city. And like I say, happy to take any questions.
Thank you very much, Dominique, and a very good paper actually. I mean, I've never shied away from the fact that I'm not a technical expert when it comes to health, but I hope I can contribute in some way by signing up to a 6-week gym course last week. This is now my 2nd week. I'm still alive, so I hope it's working to some degree. The fact that I subsequently found out the gym breached the COVID rules during the lockdown, hopefully they won't do so again. But several hands up. Have Jeanette first of all.
Yeah, thank you. I thought it was a good report as far as it goes, but I'm a bit unclear about where it fits in with the rest of the wellbeing strategy, really, because the physical activity is the sort of last bit, because it doesn't mention mental health, it doesn't mention poverty, all things that contribute to why people do not do any physical activity. So where do those things fit in? Does that come in with the main strategy? Or I suppose my main question is, what is the point of a physical one when those other things need to come into play?
Thank you. It's a really good point, and obviously we're constrained with papers to the board. I mean, it's a topic that could go on for very many pages, but it's an excellent point. And I think there's those 2 strategies I mentioned, not just the health and wellbeing strategy, which obviously focuses for now on active travel and air pollution, but also the physical activity strategy, as I said, which is the Hampshire and Isle of Wight wide physical activity strategy, looks in much more detail about those levers that can prompt the least active to become more active, and does address some more of those barriers, I suppose, such as mental health and opportunities such as improvement in mental health, and looking in greater depth at particular projects to enable those groups to become more active through various different ways. Does that go some way to answer your question? It's hard to go into. I'm happy to talk offline about the much more detail about the different projects that are going on.
No, it does. It does beg a further question, is whether we should be focusing on certain areas that we know are deprived areas, Charles Dickens, Buckland, and focus our energies on trying to get those areas active, and then that spreads out to the rest of the city. But I bow to professionalism on that. I'm sort of just a layperson, really.
No, I think it is a very valid point, and I think it's a yes and kind of a response, in that a lot of these are population level measures, and there's a definite need to focus on areas of higher deprivation where we know physical activity is lower than not just the Portsmouth average but the national average as well. So I think it's I suppose it's the scale at which we work at. Small incremental changes at a population level can actually make a massive difference to all of our health, and we need to make greater efforts for those in greater need.
I'm sure the people who are setting budgets are hearing that message.
Thank you. Jo.
Thank you, Dominique. And I agree, it's a really helpful strategy, and I think that the need to focus on, I would echo Councillor Smith around the need to focus on areas of deprivation as well. I think the bit that when I read it, the bit perhaps was missing is, and it's a post-COVID phenomenon, I guess, and particularly for a lot of our staff as we sit either the council or the CCG, but other employers, the move to work at home from a number of offices in the city and beyond, I think isn't going to go back in quite, I don't think there's going to be that mass rush back in perhaps the same way. We've all talked about hybrid working, etc., etc. And I wonder if there's more we need to do as a board to look at how do we support employers with that, because if the majority of their staff are working at home, they're not walking to work, they're not, you know, going for a lunch break around the block. So are there things we need to maybe think differently about than we did pre-pandemic about how employers as employers ourselves, we can support staff with some of that who may only be, you know, going down the stairs now in their own home. And I just thought that element might be missing, and is perhaps, we may perhaps be creating a bigger issue for ourselves collectively if we don't sort of seek to tackle it in some way.
I think that's a really good point, actually. If I can briefly come back, it's an excellent point, and you're right. It isn't in this paper, but I do think it's potentially something that we might consider now that we've had approval for the strategy. It might be something worth considering as an important factor in the strand and the active travel and air pollution strand going forward. We do move less. I know I personally move less. So as a population, we all move less than we did. So yes, I also think there's a crucial role for board members and then their organisations as anchor institutions to be leading that drive. Again, sorry, terrible with the puns today. To increase active travel for the health of our staff and our patients. We're all one population, so I think there's an opportunity there as well.
Yeah, that you said it much better than I did, Dominique. I think it's that point. How do we as a board support ourselves as employers and our staff, but also more widely in the city around that? Thank you.
Thank you, Susie.
Thank you. I've got a couple of separate points. Actually, I had the same points as Joe and Jeanette. On the working from home thing, I think it's really crucial. I was delivering a training day yesterday, and I told everyone they had to go away and do something during the lunchtime and not do their emails. Of course, I couldn't control it, but in telling other people to do it, I made myself do it for the first time in absolutely ages. So I do think it's a really good point, that one. And also thought the same as Jeanette with the link in with other strategies. I suppose I come back to my earlier point. I think I've created myself a new little slogan, which is strategy synergy. I've just written it down here. But I actually think that's right. I think sometimes you have to just shine the light on one variable. And I guess that's what this is doing. This is saying, we're going to look at physical activity. We know that it interrelates with loads of other things, but actually let's look at this. And I think that's a really important thing, but also we need to work out where it links with other things. A children's physical health strategy, I must confess, I started panicking then because I thought I actually don't know whether I've actually read that. Does it mean that I haven't been involved in loads and loads of initiatives around children's health? No, it doesn't. So it's about being aware of how it all links together. And just the final point I wanted to say was about taking one of those examples. I've been heavily involved in the school street, and it is so much more than physical activity, but the physical activity leads to those other things, and it's around community, it's around conversations, it's around language, it's around so many things that will ripple out into better health generally. So I think sometimes these things look a bit piecemeal, but we actually have to also trust the rippling effect that we'll have on those children and families as they engage with them. And if we can hook them in with the, Pompey monsters, then that's good enough actually, and we're doing our job. So yeah, great report. Thank you.
Thank you, Susie. Helen.
Thank you. Chair, I just wanted to come in because I completely agree with Councillor Smith and Councillor Horton. I mean, the reason that physical activities come as a strategy today is because it was its turn to update. But I think the point which Councillor Smith made is actually that it is the mega, what did you call it, Susie? The health and wellbeing strategy, I would argue, the refresh is exactly the meta strategy.
Yeah.
So, I mean, in effect, this is just one part of that, and it is connected in. So normally, traditionally, and actually I think if you go to quite a lot of other local health and wellbeing board websites and look at their strategies, they tend to focus exactly as, in a way, as Dominique's presented, is that we tend to have 5 areas that we know cause ill health, long-term conditions, and the difference in life expectancy and quality of life. And it will be the things that we always say in public health, around prevention. It's smoking, it's it's lack of physical activity, poor diet, and also alcohol, and it's safe levels of drinking. But actually, we know that we can continue to give those messages, and in a way that's what I think Dominique's report is really showing, is you can continue to give, and that report could have been about all the messages we were giving, but messages don't work, exactly as Councillor Smith has said, unless you actually are working with people in a position to make those behaviour changes, which clearly Councillor Fazakerley is doing, going to the gym. So it is those underlying, as Matt would say, causes of the causes. So normally you'd get a lovely strategy which talks about what we're doing about getting people to stop smoking, to move their backsides, to drink sensibly, and all of those things. But actually, if we continue to do that, what happens is that you increase that inequality, don't you? Because actually those people who are ready to make those changes will, and will have improved outcomes, but you're never really getting to the reason why people aren't ready, and that is those areas that have been prioritised, which is housing, education, healthy, positive relationships. It's all of those things that put people into a place where they can actually start to make those life choices in a way. And so really that's why I'm really pleased to hear. So, and it feels like I'm plugging the health and wellbeing strategy again, but it's really, if we don't change people's life chances, which we all know, we're all advocates here, we're never going to actually get those behaviours changed, which have a huge and important role in actually managing future public service demands. And that is really why it's so important post-COVID. So it's right to make those points about COVID, because actually what we've seen is a deterioration and more inequality. So it's really important, as you're all saying, that we do focus and do target. And all of the work that is behind Dominique's report is actually that targeted work to actually where we need. Some people don't need much help at all, but others need a huge amount of, it's not help, it's enabling, isn't it? And giving people empowering people to be able to improve their life chances. So I'll get off my soapbox, but I think everything you've all said is important and very much part of the work that Dominique's team's been doing. But for me, that last opportunity to do my brief intervention this is so important that all of our organisations take this role up, because it doesn't matter what we all say individually. If we don't act as those anchor institutions, we won't make those changes, and that's important for the CCG, the council, the hospital, education, business. We've got to really use our might to actually practice what we preach. So it will be our employment strategies, our physical activity strategies as employers. I mean, how much, a little challenge, but how much are we all doing, exactly, I suppose, as Joe says, to encourage our workforce to be making some of those healthier decisions? Because we all work, we get up, don't we? We all get up early, we sit in front of Teams meetings like this all day, and then we're going, eating maybe not the most healthiest food and sitting down on our backside. So it's what we preach and what we enable our employees to do, but also our deprived communities. And I'll get off my soapbox now. Thank you for giving me a voice.
Thank you, Helen. I don't have any more hands up, so thank you. I think the only drawback I'd mention, Dominique, and it's probably from a personal level, is I did, Susie, when I rejoined Slimming World as well a month ago, but the difficulty is when one's pleasantly plump and one loses weight and you're of an older age, the neck starts to go. So Dominic, if you could give me hints about equalising that, I'd be most grateful. But anyway, I have no other speakers, so thank you very much for that. The report is just for noting, so it is duly noted. Yes,
Jason, we could invest in a rack to stretch you.
I prefer a scarf,
help.
Gerald. A scarf may be better. So,
Okay.
mind you, I can do with some extra height as well. But anyway, thank you for your contribution. Right, the last item is date of next meeting. The next meeting is down for the 22nd of June at 10 AM, as per agreed at our last meeting in September. Sorry, the meeting in September. Anybody else wants confirmation? The dates after that are the 21st of September and the 23rd of November, all at 10 AM. So there being no further business, as far as I'm aware, can I thank you all for your attendance. We've lost several people, obviously, who haven't gone to other meetings, but the 23 of us that are left, thank you for your time today, and see you again. Thank you very much.
Thank you.
Thank you. Bye.
Cheers.
Thank you, everyone. Bye.
Thank you. Bye bye.